Hi, my name is Ryan Margolis, and I'm a fourth-year graduate student at the University of Texas at Dallas under the supervision of Dr. Kenneth Hoyt. And today I'll be talking about my research that involves focused ultrasound therapy and photodynamic priming to improve delivery of immune checkpoint inhibitors in head and neck cancer. Now, head and neck cancer or head and neck squamous cell carcinoma is the sixth most common malignancy, with an expected 830,000 people being diagnosed annually worldwide. And now in the United States alone in 2022, it's expected about 54,000 people to be diagnosed with head and neck cancer. Late stage head and neck cancer is marked by an overexpression or an upregulation of specific receptors, most notably PDL1 and EGFR, or the endothelial growth factor receptor. These present a prime opportunity to target for drug delivery. Now, as with any other drug delivery, the tumor microenvironment presents a physical barrier to optimal drug delivery. As we can see, as our normal vasculature on the left right here, it goes from our arteries and our veins, and we have our capillaries in between. And you can see that we don't get that same configuration in tumor vasculature. And that's because as tumor vasculature grows off these vessels in the normal tissue, they often have pores that create chaotic and leaky vessels that ultimately increase the interstitial pressure, and we get physical barriers to our drug delivery. Now, there are multiple ways to try to overcome this. The first one that's been attempted is photodynamic priming. And photodynamic priming, or PDP, uses subtherapeutic doses of PDT to modulate the microenvironment. And this increases tumor tissue permeability. Now, a phase 2 clinical trial that investigated the use of neoadjuvant PDT showed that there was a response rate of about 43%, which is quite good, but it also shows that PDT is not to be used as a monotherapy. So in another way to further improve that is to use focused ultrasound. Now, focused ultrasound and, well, the interaction of focused ultrasound and a microbubble contrast agent oscillate these bubbles, and they create mechanical stresses along the endothelial vascular walls, temporarily opening up these gap junctions to allow for more drug to be delivered into the tumor tissue. So our research project here investigates the therapeutic effect of focused ultrasound and photodynamic priming, or PDP, on improved drug delivery. To do this, we used C3H HEJ mice were implanted with a AT84 cell line, which is a head and neck single cell carcinoma marine cell line. And they were subcutaneously implanted in the left flank. Once the tumors reached anywhere between 6 to 8 millimeters, these mice were randomly and equally divided into 3 groups. The first group is our control, which had no PDP or focused ultrasound, our PDP only group, which is group 2, and our group 3, which is focused ultrasound and PDP. Now, regardless of group, each mouse received 2 different injections. The first one was a 200 microliter of lipo BPD, which is our photosensitizer, which is used with the PDP therapy. The second was injected an hour later, and it was a 50 microliter bolus injection of anti-PDL1 IR dye 800 and microbubbles. Now, this conjugation of anti-PDL1 and IR dye 800 was used to temporarily measure the drug accumulation over the 24 hours. Now, following our microbubble injection, mice that were placed in the focused ultrasound and PDP group underwent 3D focused ultrasound therapy using a programmable ultrasound scanner, which was the Vantage 256, that had a dual transducer configuration for both imaging and therapy. Both the imaging and therapy transducers were 128 element arrays, linear arrays, with center frequencies of 3.5 and 2.0 megahertz, respectively. Now, the ultrasound parameters are shown below, but there's a few to take note of. The first is that the treatment time was occurred for over a 5-minute time period at a pressure of 0.7 megapascals, and this equates to a mechanical index of 0.5. Now, The number of focal zones was 9, and the number of repetitions per focal zone was 19. And in this therapy, each focal zone was repeated 19 times or sonicated 19 times before moving on to the next focal zone. There was no percent overlap. Now, following focus ultrasound, mice underwent PDP therapy. Now, prior to this and after the focus ultrasound therapy, these mice were given an injection of meloxicam to help minimize discomfort. Now, this PDP therapy used an activation laser of 690 nanometers over 750 seconds. The dose was 75 joules per centimeter squared at an irradiance of 100 milliwatts per centimeter squared. Now, if we look at our preliminary results, we see our representative images for mice in each group. You can see your control up top, your PDP in the middle, and your PDP plus focus ultrasound at the bottom. Note that this green signal is indicative of our increased accumulation of our anti-PDL1. And you can see in this PDP focus ultrasound group, we do get that increased green signal, which correlates to an increase in drug accumulation. Now, if we look to quantify these images, we can see on our first graph here that is the optical analysis over the 24-hour time point. Now, if we look at this first group right here, we can see this graph right here that shows that our mice treated with focus ultrasound and PDP therapy showed an increased accumulation of about 145% and 531% compared to the PDP only and control groups respectively. And this is, once again, this is at this first time point right here. And then as we progress up until about that 9-hour time point, we do see that there's an increased accumulation due to the focus ultrasound. Looking at the area under the curve up until this 9-hour time point right here, we do get a 21% increase during that time period. So that does confirm that we do get an increase using PDP and focus ultrasound. So in conclusion, our preliminary results show a synergistic therapeutic effect of focus ultrasound and PDP. And we see that we do get an improved systemic drug delivery up until about that 9-hour time point. Now, looking back, our focus ultrasound can be further optimized. So in our experiments here, we used a bolus injection, but the potential for using a steady influx of microbubbles could further improve and separate the difference between focus ultrasound plus PDP and PDP only. Furthermore, in this experiment, we used a 0% overlap, so we could increase that to about a 30% or even a 50% to try to get a further more uniform energy distribution across that tumor volume to further improve drug delivery. And lastly, we're going to have to investigate the immune response that's due to that synergistic effect of focused ultrasound and PDP. As we know that both these therapies actually do increase the immune response. So we'll have to investigate those as together, which most likely means we'll have to do a focus ultrasound group as a solo treatment. Thank you very much, and I'll be happy to answer any questions.